Welcome everybody. Thank you for coming. So I'm going to go through some slides. I'll stop along the way for some questions. This is a topic that's fairly new to everybody in the country. Outpatient total joint replacement's been going on the last about 5 years throughout the nation. We started about 2 years ago downstairs. There's some new Medicare rules that make this pertinent to probably some of you in the room, and we'll go through that, whether it's right for you or not right for you. Certainly, outpatient total joint replacement is not, if you get your joint replacement, doesn't mean you have to have it outpatient. It can be done inpatient or outpatient. So I don't want people to think that this is what we do with everybody. This is very specific to certain people, but it's a great option, and we'll kind of go through all that. So the first thing we want to talk about is, what do we mean by outpatient total joint replacement? Why are we doing it? What's the purpose? Is it safe? That's probably should be on everybody's top list. And what is the future of this? Is this just a passing fad, or is this the future of joint replacement to come? So when I talk about it tonight, what I'm going to define it as is hip or knee replacement surgery performed either downstairs or across the street at the hospital, where you go home usually within about 12 hours. The technical definition is probably anybody who goes home in less than 24 hours, but the way we've been doing it is less than 12 hours. So that's just what we're going to talk about tonight, but doesn't have to be. The facility we have downstairs, I don't know if any of you have had surgery down there or walked through it, but it's 13,000 square foot accredited surgery center, state-of-the-art instrumentation. We built the surgery center for large cases like total joint replacement. Some of you may have been to like ophthalmology surgery centers where the operating rooms are small and the equipment is specifically for that specialty. Our center is built specifically for bigger cases like total joint replacement, spine cases, and then all kinds of orthopedics. And you need special sterilizers. Anybody who's had a total joint or seen total joint know that we need a lot of equipment. And the sterilizers we have are hospital grade. They're not your typical outpatient sterilizers. We also have some beds that are designed for folks to stay a while. They're not stretchers. They're actual beds that people stay for 4 or 5 hours after surgery. So there are some specificities that we've built into the facility downstairs that really help us do this procedure. We deal with a lot of patients in this community that are of Medicare age meaning generally over 65. And the volume of total joint replacement, you'll see TJR, that means total joint replacement in all these slides, is slated to increase 5 to 10 times in the next 15 years. So there's a large number of these procedures being done. The question is, can they be done more efficiently, more effectively, with better recovery at home as opposed to better recovery at the hospital, and safely? And as you folks know, Medicare patients are living longer, they're more active, and many patients who are 65 to 75 are as healthy as those that are 55. So what's the difference in doing folks that are older than 65 as opposed to younger than 65? And this all came about mostly by patients. Most people don't want to stay in the hospital. They don't want to eat hospital food. They don't want to be woken up 20 times at night to get your temperature checked, and they don't want to be there. So the trend in all procedures, especially orthopedics, I don't know if any of you have ever, 20 years ago we were doing shoulder surgery, rotator cuff surgery, ACLs. Those all stayed 2 or 3 days in the hospital. You can't find anybody to pay for those procedures in the hospital now. They're all done outpatient. So the trend in a lot of surgeries is less and less invasiveness, less and less recuperation in the hospital. So the benefits, obviously, of going home are friendlier environment, maybe, we hope, at home. Potential decreased infection risk. Potentially there's less sick people at your house than there are in the hospital, we would hope. And of course, what Medicare is concerned about is increased value. Is it a better product for a lower cost? That's what we're all looking for in the healthcare environment. A decision made in November of 2017, Medicare actually is allowing joint replacement, total knee replacement, to be done as an outpatient. That was beforehand not allowed. You couldn't. So last year, if I saw you and said, you know, if you tell me you've got Medicare, you want your joint done outpatient, I can't do it. That's not the case anymore. That has changed. Does that mean you have to have your joint replacement done outpatient? Absolutely not. There are many, many reasons. We'll go into some of them. Some people are just not good candidates for outpatient surgery. It's not safe, it's not convenient, and it's not good care. So just because they allow it does not mean that they won't pay for it if you stay in the hospital. That's a key factor tonight. So don't come away from this saying, my doctor said I have to have it outpatient. That's not the case. Any questions on that before we kind of move on? Because that's a key factor. We good so far? All right. So why are we doing this and how are we doing it better? We're a single specialty facility downstairs. All we do is orthopedics. When you have surgery done at the hospital's trying to do 12 different kinds of surgeries. The surgeries we do are very specialized. We have our own specific staff. We have less bureaucracy, more personalized care. And quite frankly, the surgeons, the physicians are more in charge of their environment downstairs than when you go to the hospital. You have hospital administrators kind of making the rules. So we believe, and most folks believe, that a surgery center environment is a little more efficient and better for the patients. This was a national survey, and we ranked in the top 1% for patient satisfaction in our patients downstairs. So we were pretty proud of that. So how does it work? If we do decide to do your surgery outpatient, how would we do it? We do a lot of education on the front end because these surgeries obviously have been done in the hospital for years, and most people are prepared to go to the hospital. We do a lot of education on how you're going to recover at home, what to look for, what are the problem areas, what should I be concerned about. I always call my patients the night of surgery and go over questions with them because a lot of times you don't hear things before surgery. So you want to know, you want to make sure people are tuned into all that after surgery. We use some less invasive surgery, which helps a little bit, and the biggest thing is teamwork. We all work together, the anesthesiologists, the nurses, we're all on the same page with all of these surgery. So probably number one there is the most important thing is screening patients before surgery. You don't want to have surprises, or try not to have surprises during or after surgery. So we spend a lot of time on the front end working with your family doctor, your cardiologist, your pulmonologist, and we're especially doing the surgeries downstairs. We're super selective. We have cutoffs for weight. No defibrillators, no pacemakers. But that doesn't mean they couldn't be done at the hospital safely outpatient. It just depends. But again, educating folks up front. Not everybody's spouse wants them to come home that night, or feels comfortable with them coming home. You know, you gotta participate and help them get their medicines and help them get the walker. So it's teamwork. You got to have good social support at home. We like folks to see the facility, and then finally, I think follow-up phone calls are invaluable. Like I said, I call people the night of surgery after we do it downstairs to check on them. Then we call you the next day. They're up here in therapy the following day or two after surgery. So Lance, who's standing back there, can come to us if there's a problem. So you don't just discharge patients home and they say, see you in 2 weeks, hope you do all right. You gotta stay involved. We want you to call us. We want to call you. There's definitely dialogue that needs to happen, because a lot of people, you know, the first response is they're having pain, their incision doesn't look right, they run to the emergency room. And that's not what we want you doing, because we can handle most things over the phone or even in the office rather than running to the emergency room. Once you run to the emergency room, you're going to get doctors that don't look at knees, they don't look at hips, and they're going to admit you to the hospital, and it's a chain reaction there of things that you don't want to have happen to you. So if possible, we want to try to solve all that stuff on the front end before you unnecessarily go to the emergency room. Not the emergency room is a bad place. If you need it, you need it. But we try to avoid a lot of that unnecessary care if possible. On the day of surgery, and a lot of these, as somebody just said, a lot of these I do at the hospital too. So it doesn't mean that you would only get these downstairs. It's just a little bit more efficient, a little more teamwork downstairs than I have over at the hospital. We do some oral medications. Most of our surgeries are done under what's called spinal anesthesia, which means it's a shot in the back where your legs go numb for about 2 hours. You also get medicine to take a nap, so you're not aware of the surgery. An adductor canal block is a fancy word for a special nerve block that we do. We also do shot injections into the knee and the hip during surgery to help with pain after surgery. We try to get away from narcotics. I don't know if you guys have ever used narcotics. Those are things like oxycodone, hydrocodone, Percocet, Norco. Those cause a host of problems: constipation, nausea, addiction. We try to, obviously we need some of those, but we've really, when I first started 15, 20 years ago, we were giving everybody a morphine pump after surgery. The first thing you got when you got to your room is you start pushing the button, morphine pump. And people were throwing up, constipated, staying in the hospital a week. You're treating side effects of medication more than you're treating the actual pain. So most of our folks we get home within 6 hours after the surgery. So at the time, this is a knee replacement. This is, these pictures are showing just before we've put in the final implants. We do an injection all around the entire knee. You can't really get it in the bone, but we get it in the nerves around the bone, what's called the capsule of the knee, which is the envelope of the knee, all the muscles. We inject those with numbing medicine that lasts up to about 24 hours or so. So that really helps with pain a lot. You're not getting that sudden bad pain right after the spinal anesthesia wears off. Again, these are things I do in all my joint replacements. So just because if you have it one place or another doesn't mean you're not getting this or you are getting this. So these are advances we use whether it's inpatient or outpatient. This is the nerve block that we do for knee surgery, not for hip, but for knee surgery. It's a block that goes in the thigh that helps with nerve pain down into the knee after surgery. There's a bulb, it looks like a water balloon of medicine that you carry around with you. Sometimes we'll leave that in for about 3 days and have it pulled out in therapy. So that really helps. The worst pain in knee replacement or hip replacement is in the first 24 to 48 hours. So this really helps get you over that hump so that you can do therapy, not take a bunch of pain medication, and really be fairly comfortable living your life without having to have pain. Again, I mentioned why we try to avoid narcotics. Any of you who have dealt with that can attest. There's a lot of problems with taking these medications. Yes, you'll need some of them, but we start low and kind of work our way up rather than starting high and work our way down on those. So we're using less and less and less of these as time goes on. This was that nerve block that I told you about, and this is where the nerve block goes. That's right in the thigh, and that stays in usually for about 3 days or so. That's put in by the anesthesiologist, sometimes before your surgery, sometimes after. Doesn't really make a difference. But less invasive surgery, somebody asked about that a minute ago. With the hip, we do what's called an anterior approach to the hip, which we cut no muscles. It's about a 3 or 4 inch incision in the groin. It's hard to see the picture up here, but there's a interval of muscles that you basically just split and you're down to the hip joint without really disturbing much. So we have a specialized table that we do this on. I'll show you that in a minute. You can get up, put full weight on the hip after it's done. With the approach in the past, which used to be through the back, there was some restrictions, no bending, no crossing your legs. None of that is needed with this. The example of the table is on the top. That's a contraption that helps us look in the hip better, move the leg around. And this is actually in the operating room. We're able to use X-ray during the surgery to help put the components in the appropriate places, get the leg lengths correct. All of that's done during surgery. And the spacesuits also help prevent infection as well. So these are folks for outpatient surgery. These are just some general things that we look for. Age less than 75 is, again, that's a rough guide. There are folks older than that are probably healthier than some that are younger than that. So that's just a general guide. Medical problems, that's the most important thing we look at before age is medical problems. And diabetes, COPD, obesity, smoking, heart disease, those are all things that circulation disease, those are all things that we look at pretty closely. Again, not just having one may not disqualify you, but we actually have scoring systems now. It's pretty well thought out where you can fill in and give somebody 2 points for this, and then at the end you get a score, and that score can give us a pretty good idea of your relative risk of this surgery, be it outpatient or inpatient. BMI of 35, again, we like to stay below that for various reasons. You have to be very motivated. If I suggest this to somebody and they're resisting it, I don't even argue with you. The last thing I want to do is talk you into some surgery that you're going home and you're upset about and your spouse doesn't want you to have. So you have to basically tell me, I want this done outpatient. I want to go home after surgery because it's not for everybody. And again, we mentioned the social support. You need friends or a spouse or neighbor or somebody who's going to check on you and be with you at least that first night. When we send you home, you have a lot of prescriptions. We also put some what's called some foot pumps on you to help prevent blood clots. Blood clots are something we worry about with any hip or knee replacement surgery for the first several weeks. We're very diligent about checking on folks, calling you. Therapy starts right away. We have therapy here, so we're able to kind of keep an eye if something's not going well. You don't even have to read all this. This is just studies that have been done to say that it is safe. Outpatient joint replacement is safe, and multiple studies have been done with large numbers of patients, really showing no difference. The bottom line says with diabetes and age over 85, the risk factors were much higher. So there are things that do put you at higher risk. This is a study with hip replacement. They did 78 inpatient, 78 outpatient, and there was really no difference in those two groups. So it is safe in the right folks. Not for everybody, but it is safe. This is just some of our own data downstairs. We've been doing this now since November of 2015. We've been super selective, so we've only done 123, which it is a lot, but we've been very selective on who we've done it with. You can see knees, hips, and shoulders. These are the age range. We've stayed with younger folks in the 60s. Partly that was Medicare rules. You couldn't do it. So we did some older folks, but not a lot. These are the average surgical times for a knee and hip, and I don't do shoulders, but my partners do the shoulders. It's about an hour to an hour and a half for a knee or hip replacement. Big thing, this is a good slide I want you to see. This is the time from when you came out of surgery to when you go home. So you can see all of those are shoulders again are quicker, a little less surgery, less pain. Those are the quickest recovery. But all of them are around I don't know, what is that, 4 to 5 hours, something like that. So pretty good recovery. As soon as the feeling comes back in the legs, we get you up with therapy. There's not a lot of laying around. There's not a lot of drugging people with a lot of sleeping medicine and pain medicine. We really get people up and moving. And the feedback from folks who've had it done is they would definitely do it this way again. These are our average pain scores. So just, when you ask somebody, is it the worst pain of your life? That's 10 out of 10. 0 to 1 is not much pain at all. 3 to 4 is mild to moderate. The worst pain is on the day after surgery. If any of you have had a joint replacement, you know that first day you've got a lot of medicine on board. You don't feel a lot of pain. The second day tends to be the worst, and that's when our scores are still very, very mild pain, and the satisfaction is great. Like any procedure, there are complications. We've had to, you can see so a hospital transfer means during surgery or after surgery, do we have to ship somebody over to the hospital? We've never had to do that. We had one person readmitted for another problem, one minor infection. We've not had to transfuse anybody, and DVT and PE are blood clots or pulmonary embolus. So those are good numbers. And I don't have the data from the hospital, but my hospital patients are obviously a little bit sicker, so the numbers are probably a little bit higher there. So what if we had a problem? If you had a problem downstairs and couldn't go home or had an emergency, we have a transfer agreement with the hospital where we can ship you over to the hospital. We also have agreements with local assisted living and skilled nursing facilities that you could go. So just in summary, why are we doing this? It's patients who want this, not doctors, not administrators. It's patients who are driving the whole outpatient surgery theme. But we're able to do it safely. We're able to do it with less pain. We have there's a substance called tranexamic acid, which is developed on the battlefield, which really reduces blood loss in folks and has reduced our transfusion rates to less than 5% or zero downstairs. So there's advances that are made in all of medicine that trickle down to us. And again, it's a team approach with all of us.